We are live, sir.
Good evening, everyone. Today, as we start with our IPCA's experts outlook for the India's Diabetes Challenge, today we have two eminent doctors with us from the city of Bangalore. Dr. Ganpati Bantwal, who is who is MD, DM, and DNB endocrinology from St. John's Hospital, Bangalore, and Dr. Vagesh Iyer, who was a former doctor is professor and former head of the department for of endocrinology in Bangalore. So I welcome both of these two doctors, and the today's topic would be gliclazide, the 21st century sulfonylurea. So I hand over the session to Dr. Vagesh Iyer, who would be moderating the entire session for us today. Over to you, Dr. Vagesh.
Mithun,
Yeah.
I think he's.
Yes, sir. You are there.
Okay, I'll take over. Yeah. Good evening. Welcome to this very special topic on the diabetes, that is 21st century sulfonylurea glyclazide. We are, myself and Ganapati, we are good friends. We are colleagues at St. John's. We have led through the era of sulfonylurea, well leading into the SGLT2 inhibitors. In fact, when we started our residency nearly 2 decades back, metformin and sulfonylureas were the primary drugs for the management of diabetes, and it was true even now, though the percentage of the sulfonylurea used may have come down because of the newer agents like DP4 inhibitor and the SGLT2 inhibitor. But over the years, the sulfonylureas have proved their presence. Even in any country, the biggest number of prescriptions after metformin is going to be in sulfonylurea. Among the sulfonylurea, glyclazide has got a unique properties. To speak on that unique properties, we have got Dr. Ganapati. He is an expert in this field. I welcome Dr. Ganapati to speak on that 21st century sulfonylurea, that is glyclazide.
Thank you, Dr. Vagesh, for the kind introduction. Thank you, IPCA, for giving me this opportunity. Yeah. So I'll be talking on role of sulfonylurea in the 21st century with a focus on gliclazide. As Dr. Vagesh has rightly told, that we have been using sulfonylureas for many years. And this has the advantage of multiple formulation, low cost, minimal side effects, efficacy in controlling hypoglycemia, and reducing microvascular complications. Recently, concern has been raised with respect to their possible adverse effect. In addition to the risk, increase in the risk of hypoglycemias, SU's query, there was a suspect for, they were telling it can produce increased beta cell apoptosis and beta cell exhaustion, endothelial dysfunction with increased risk of ischemic complication, and possibly an increased mortality risk. Also, the ACE and the ACE stated risk for hypoglycemias with SUs exceed the risk with metformin or TZDs, and the combination of metformin plus SUs associated with 6-fold greater risk of hypos. Though not explicitly stated, the statements implied that SUs should be considered third or fourth line agent. So now coming to the classification of SUs, the first generation tolbutamide, the problem started with tolbutamide from the UGDP study. This study was actually criticized because it was not well done. And that's the reason, so this all the problems started. The chlorpropamide, which we don't use it now, acetohexamide, and tolazamide. The second generation, we have glipizide, gliclazide, glibenclamide, and including glimepiride also. So how does sulfonylureas act? So normally what happens is when you take glucose, it will enter via the pancreatic beta cells into via the glucose transporter 2. The glucose gets metabolized to ATP. This ATP will produce what is known as closure of the potassium channels, which leads to depolarization. and that leads to opening of the calcium channels, and that leads to insulin release. This is in a normal person when the glucose enters. How does the sulfonylurea acts? It binds to the sulfonylurea receptors, which are on the surface, which is close to the potassium channel. The binding of the sulfonylurea to this receptor will produce closure of the potassium channel, because that leads to depolarization, and in turn will lead to exocytosis of insulin. So you have the different classes, and if you see the PK/PD properties, glibenclamide is quite long-acting. Its metabolite also has long-acting, and it's a very potent drug. So that's the reason what can happen is, if you get hypoglycemia, we'll have to actually treat this patient for at least 36 hours, because the metabolites are also having hypoglycemic potency. Gliclazide, glipizide, so they act for up to 12 to 24 hours. It has a better effect. In fact, if you see, the protein binding is actually lesser with the gliclazide compared to that of glipizide. Bioavailability is 80% with gliclazide, 100% with the glipizide, 99% with glibenclamide. Glimepiride is 100%. Okay. Half-life is 10 hours with the glibenclamide. That's the reason it has, more importantly than the half-life, the metabolites have a hyperglycemic potency. Gliclazide is 8 to 12 hours. Glipizide is 2 to 5 hours. So glipizide is a shorter acting. You have to use it twice daily. If you see the renal excretion, glibenclamide 50% renal, excretion 50% is renal. Gliclazide is 80% renal, glipizide 80% renal, glimepiride is 60% renal. Otherwise, not much changes, rest of the things. So what are these ATP sensitive potassium channels, SU receptors, the sulfonylurea receptors? The SUR1 is present on the neuronal cell and the beta cells. The SUR2A is present on the cardiac and the skeletal muscle. And the 2B is present on the smooth muscle. So if you see long-acting kinetics of different SUs, long-acting drugs like glyburide, so they have increased hypoglycemic potency even at evening, because at the time the physiological levels of glucose are actually lower. If you see gliclazide, the onset of action is rapid. So glyburide, though it's rapid acting, it has a longer half-life. It's long acting. Same thing with glimepiride also. So the chances of hypos could be more for that. So drugs short acting whose kinetic matches the physiological levels result in minimum or no hypoglycemic events is the best choice. Coming to HbA1c reduction, insulin is the best, but then after that you can see that SUs are number 2. Including SGLT2 is just 0.85 when you start with an A1C of around 8%. Sulfonylurea remains the best when it comes to efficacy in blood glucose lowering. Certain shortcomings makes doctors to think before prescribing it, like hypoglycemia, cardiac safety, renal safety, beta cell overload, weight gain. So these concerns can't be generalized to all sulfonylureas. So do we have an answer to all these concerns? So what is the criteria for an ideal SU? It should have a good HbA1c lowering. It should be CV safe, should not prevent ischemic preconditioning. It should be safe in diabetic patient with kidney disease, low incidence of hypoglycemia, should not exhaust the beta cell, extra pancreatic effect beyond insulin secretion, and low potential for weight gain. How is gliclazide different? It has a separate structure known as the amino-aza-bicyclooctyl ring. Now, because of this, it possesses hemorheological properties. It reduces platelet reactivity, stimulates endothelial prostacyclin synthesis, increases fibrinolysis, and possibly because of reduction in oxidative stress. So if you see the mode of action of gliclazide, so normally, as you know, when when there is an increase in insulin, the glucose comes down. Gliclazide binds to SU receptors on the pancreatic beta cells And this binding closes the linked ATP sensitive potassium channel, which leads to decreased potassium efflux, which opens a voltage gated calcium channel and results in influx of calcium. And then that leads to translocation and exocytosis of secretory granules of insulin into the cell surface and thus insulin release. But then what is important with gliclazide, which is not seen with others, is it is the only sulfonylurea reported not to bind to EPAC2. This is a stimulating factor for insulin exocytosis. So that's the reason you find that gliclazide confers lower risk of hypoglycemia compared with others. Gliclazide is a smart SO. It shows its maximum effect within 1.5 hours, covering highest spike after breakfast. 10-year half-life ensures lowering of PPG spike after lunch. Short half-life and reversible binding and no active metabolites ensure least concentration of gliclazide in evening. This is the same thing, this is the same time when 2/3 of the hypoglycemic events are observed by the patients. HbA1c lowering. So you can see here, when you have an A1C more than 10%, it can even reduce up to even 4%. At 9 to 10, 2.6, at 8 to 9, 1.7, at 7 to 8, it's around 0.9. So reduces A1C less than 7% within 6 months. So this is from the advanced trial. So 8 out of 10 reached an A1C less than 7% in this advanced trial. This reduces HbA1c less than 7% irrespective of BMI. There was a study known as the Satoh study, so where they compared glibenclamide with gliclazide. So years until the start of insulin compared with the gliclazide and glibenclamide. So it took 14.5 years. Then we had to add actually insulin compared with just 8 years after glibenclamide, telling that it can produce what you call, it is flogging a tired horse. This happens with the glibenclamide, unlike this. So intensive and long-lasting glycemic, prolonged insulin-free period, and significant delay in insulin initiation. To the risk of hypoglycemia in patients treated with gliclazide versus other SUs. So these are some of the studies. So you can see here, if you compare gliclazide versus other SUs, so the event rates are actually lesser compared to that of other SUs. And then if you see, the weight also is lesser compared to other SUs. So everything favors gliclazide. Intensive glycemic control and the prevention of cardiovascular events, implications of the ACCORD, ADVANCE, and the VA diabetes trial. So in the ACCORD, 16.2% in the intensive arm had severe hypoglycemia. ADVANCE, it was just 2.7 where gliclazide was used. And the VADT, it was 21.2%. So you can see here also with the gliclazide, it was found that the hypoglycemias were lesser. Then there was another study known as a GUIDE study, gliclazide MR 30 to 120 milligrams daily and glimepiride 1 to 6 milligram daily as monotherapy or in combination showed no major hypoglycemia for similar HbA1c reduction in both groups and irrespective of age. So another study, lowest hypoglycemia was comparable to that of DPP4 inhibitors. In fact, 2.1 in the DPP and gliclazide it was 1.8 episodes of symptomatic hypoglycemia. So risk of hypoglycemia is lowest with gliclazide, whereas it was almost 4 times or 5 times with glimepiride. Coming to the pancreatic effect, gliclazide reduces beta cell apoptosis. You can see here the beta cell apoptosis percentage of control maximum with glibenclamide because it strongly stimulates, it acts on the EPAC2, whereas gliclazide does not act, and that's why you get this beneficial effect. So this was beta cell apoptotic. You can see here hyperglycemia with gliclazide. This actually comes down. This is hyperglycemia with glibenclamide. Apoptosis increases. This is only hyperglycemia, and this is normoglycemia. You can see the difference when when you give gliclazide versus glibenclamide. CV benefits. Gliclazide binds with high affinity and high selectivity to the SUR1 receptor with reversibility. And this provides CV protection as it does not bind to the sulfonylurea receptor 2A, which is present in the heart. And vascular benefits of gliclazide beyond glycemic control. So this is a control. If you see the monocyte adhesion before gliclazide and after gliclazide, so it has come down. So the adhesion of monocytes comes down. Gliclazide increases endothelial nitric oxide and decreases peripheral resistance. So this is a small study where they found that gliclazide treatment improves both antioxidant status and nitric oxide mediated vasodilation in diabetic patients. It also reduces LDL oxidation via it increases the resistance of LDL to oxidation through its unique free radical scavenging effect, and via that it actually reduces LDL oxidation. So baseline, so you can see here LDL oxidation lag time is more compared with other sulfonylureas. So when you have low LDL oxidation, that means there is reduced atherosclerosis. So it's effective against the formation of oxidized LDL cholesterol, similar to that seen with vitamin C. Other SUs had no effect. Gliclazide and CV protection. So if you see overall meta-analysis which came in the European Heart Journal, it was actually lesser, 13.7% less compared with others. Glimepiride, it was 32%, 63.7% with glipizide, and 50% with glibenclamide. Gliclazide is better than other SUs in CV events, as I told you in the advanced trial. It did show benefits. So where gliclazide was used, whereas others where glimepiride or glibenclamide was used. So mortality and cardiovascular risk associated with different insulin secretagogues compared with metformin in type 2 diabetes with or without a previous MI, a nationwide study which came in the European Heart Journal. So you can see here gliclazide was all-cause death was not, it was neutral. Cardiovascular death once again was non-significant. AMI stroke or was, it did show a slight increase, but then this is for no previous MI compared with metformin. With previous myocardial infarction compared with metformin, it was actually once again not significant. This actually had the least compared with others. If you take all-cause death was actually reduced. So here also all-cause death was reduced. So overall mortality comes down. Even if you see the cardiovascular death, that also actually was, it was neutral. What about in chronic complications, gliclazide and diabetes complication? New or worsening macroalbuminuria, nephropathy, CV mortality, it did show a risk reduction. So once again published in the New England Journal. Now, what is the mechanism of this? That's because of this unique free radical scavenging ring. So that reduces oxidative stress. And as you know that nephropathy is linked to oxidative stress, so which can lead to a protective effect on kidneys. And also you can see that it can slow down the atherosclerotic progression, which can happen. Gliclazide and renal protection. New onset of albuminuria reduced by 9%, microalbuminuria risk reduction of 30%, 21% risk reduction of new or worsening nephropathy, and 65% risk reduction of end-stage kidney disease. What about in CKD patients? What does the KDIGO guidelines say? For gliclazide, you see that no dose adjustment is required. The renal clearance of unchanged total gliclazide is low, less than 1% of the total administered dose, making it possible to use the drug in renal failure without any dose adjustment. This is the KDIGO's guidelines. No dose adjustment required in CKD 3, 4, and 5 non-dialysis patients. What about weight gain? So this is in comparison with TZD, insulin, TZD, and insulin. You can see here the weight loss of 1.6 kg in gliclazide-based intensive glucose control for patients not taking insulin or TZDs. So different trials and weight gain. So weight gain at the end of follow-up in the VADT, ACCORD and Advance. Advance, you can see hardly any weight gain compared with ACCORD or VADT, where other drugs, SUs, were used. Safety and efficacy of gliclazide as treatment for type 2 diabetes, a systematic review and meta-analysis of RCTs. The new Dutch type 2 diabetes management guidelines specifically advises gliclazide as a preferred second treatment option and not SU as a group because of its hemorrheological and fibrinolytic properties of gliclazide, lower incidence of hypoglycemic events, less weight gain while using gliclazide, favorable cardiovascular safety profile, no dose adjustments appear necessary in case of impaired renal function. So what does the guidelines say? The global guidelines for type 2 diabetes. Outcome studies compared with other agents are limited, but both the UKPDS and the advanced studies showed that intensive therapy with the SU-based treatment improved long-term outcomes. The advanced study achieved this without weight gain and with low rates of hypoglycemia. Modern SUs, this is the safest consensus. Modern SUs like glimepiride, gliclazide modified release should be initiated early in the course of type 2 diabetes to achieve maximum glycemic benefits and obtain the benefits of metabolic memory. Modern SUs like glimepiride, gliclazide MR should be preferred over conventional SUs in view of the reduced mortality, all cause and CV mortality, and better CV outcome, which is a composite of acute MI, stroke, and CV mortality and renal protection. Modern SUs should be preferred over conventional SUs in type 2 diabetic patients at increased risk of hypos. Modern SUs should be preferred choice of SUs in overweight or obese type 2. And gliclazide MR should be preferred over conventional SUs in patients at increased risk of CVD or with CVD. So coming to my last slide, why gliclazide? Reduction of A1C by more than 4%, unlike other SUs when you start with an HbA1C of more than 10%. Cardiac safe in diabetic patients with kidney disease. It follows circadian glycemic variability, so less chance of hypoglycemia. Restores first as well as second phase of insulin release. Protects beta cell apoptosis. Extra pancreatic effect. Low potential for weight gain. So thank you for patient hearing.
Thank you, Ganapati. I think it was an excellent talk, right from the basics to the mechanistics of action and also the CV protection and the guidelines across the globe mentioning the use of a gliclazide. So I have a certain questions because now the gliclazide and the glimepiride, these are the two things. Among the slides you have shown, gliclazide little stands out. But a recent study is showing even a glimepiride is also a better. So how to rate both?
Okay, so I think the Carolina study, which was mainly done for linagliptin, but then they also found that glimepiride was actually neutral, you can say. It did not produce any harm.
Yes.
It could be neutral, that's fine. But then if you see the guide, which was head-to-head comparison, so their hypoglycemias were more with glimepiride compared to that of gliclazide. Secondly, because of this structural advantage, it has this effect of hemorrheological properties, which is not there. And finally, weight gain, and also I compared it with the durability is actually better. And also, it does not act on the EPAC2, which is seen with all others. So that's why the beta cell exhaustion happens with other compared with gliclazide. So yes, in fact, there was a recent paper in Lancet where they compared glimepiride with the gliclazide on the CV thing, and they told glimepiride is having higher risk compared with that. So this is a meta-analysis just published, I think, this year beginning or last year end.
Yeah, I think there are no questions in the audience, but just to clarify certain doubts about the general audience, I'll be asking, is there a difference between the immediate release and extended release in a gliclazide?
Yeah, so actually immediate release, I usually prefer when somebody has fasting hyperglycemia. So if you find somebody, if he has fasting hyperglycemia, then immediate release is better, because the the extended release predominantly controls more of postprandial than fasting. So this is one difference you can say. Some difference is there. But if you see the hypoglycemic potency, it's more with the, if at all, if you compare this, the immediate release has a little bit more compared to that of the extended release.
Fine. So what about the renal safety of the glyclazide?
As the KDIGO has clearly told that you don't require dose adjustment, but common sense tells that if the sugars become normal with that, you slightly reduce the dose, because we don't want him to go for hypoglycemia. So if the glucose is 90 and 130 and he's on 80 milligram, you reduce it to maybe 60 or 40. You reduce it, because the next step is he may go in for hypoglycemia, because it's unpredictable food habits in them. So that's why.
I have one more question. It's more of a logistic rather than the science. See, I think all metformin, they came with 500, then subsequently 850 and a 1 gram. Why glyclazide took such a long time to come out with a 1 gram preparation, 80 bar 1 gram?
In fact, I told them, and hence they brought it. So this advice was given by me to one of the companies. I told, we are lacking this.
Yes.
So in fact, now they have come out, and now onwards, we will be writing more of that. So because you have it, it was actually a mistake from the company point. It's nothing this one.
Yeah.
Any questions?
No, I don't see any questions in the chat box, but indeed it was a great lecture. I learned a lot. I'm sure the audience are also benefited from the talk.
Sir, can we ask one question, sir?
Yeah, please, please.
Sir, currently when you are seeing that when some gliptins are going off patent, how do you find the competition between vildagliptin and the modern sulfonylureas like gliclazide, sir?
See, what happens is diabetes is a progressive disease. The only thing is, the question is whether you want to use it second line or third line. That's a question. Suppose somebody has very high HbA1c, say his HbA1c is 9.5. Then my choice will be not DPP4 inhibitors. My choice will be an SU. Suppose somebody is already on metformin and his HbA1c is 7.5. Then I may not use a SU, because I'm worried about that. You just require to reduce by 0.5. Suppose if it is 8.5, then once again I will use. Secondly, depending on the type of patients. Suppose if he is lean, then I will try to prefer using a SU compared to that of a DPP4 inhibitors. So it is individualistic. And since diabetes is a progressive disease, we will continue to use that.
Right. Right. Yes, sir. Dr. Vagesh, are we done with the questions, sir?
I think the talk was so in depth. I think audience were convinced with the glyclazide, its benefits, its guideline recommendation and everything. So even the minor doubts which were there were also clarified by the subsequent thing.
Right. Yeah. Right, sir. Okay, so with that, I will thank you, Dr. Vagesh also, and Dr. Ganpati Mandwal also, for shedding this light on gliclazide, the 21st century sulfonylurea. I hope that the audience have liked the current session about the gliclazide and its benefit, and how it is beneficial in their daily practice in terms of diabetes management. So I thank you both of them, Doctor, from IPCA itself. So thank you very much, sir.
Thank you. So, good night.
Good night.
Good night.
Bye. Thank you.
Thank you.
Suresh. Yeah.
Yeah.
Okay.
Okay. Thank you, Muthinji.